practitioners, rather than trying to go after all the underlying borderline pathology, will simply address the borderline symptoms. And given the difficulty, the challenge, the hassle, and the dubious prognosis of trying to treat the borderline pathology, it would be difficult to be too critical of these practitioners. However, the problem is, when you try to just treat the borderline symptoms, you run into the same problems you run into when you try to treat the borderline pathology. They will resist, they will sabotage any kind of attempt to get control of their symptoms, or any movement, any systematic movement towards a more healthy adjustment. So while it seems like it might be an easy road to just treat the symptoms of borderline, it's oftentimes the correct strategy, but it's really not any easier than trying to treat the borderline personality. What then is the true nature of a borderline? Few people in the field are really bothering with the question. And there really is very little consensus as to what the true nature of a borderline is. One important theory has to do with the separation individuation phase of development, with the key emotional patterns occurring early on. The model for the borderline pathology is the 2-year-old, just attempting to separate and break away from the parents and discover the world on his own. Of course, such a move is accompanied by a strong need for reassurance. The borderline's parents take it on the chin with this theory. Presumably, the borderline's parents are either completely controlling or overprotective of the borderline in not allowing the child to separate, not allowing the child to break out and discover the world on their own. Or the borderline's parents are rejecting of the child for wanting to separate, or angry at the child for wanting to separate. Accordingly, the borderline is perpetually testing the limits in relationship. Always feeling that significant others are trying to control them. Always feeling that significant others don't care about them. Always fearing that significant others are getting too close. Always fearing that significant others are trying to abandon them or separate from them. And finally, always feeling like they cannot make it on their own. If you've ever been tempted when you're working with a borderline to say grow up, or if you've ever thought they're acting like a 2-year-old, your thinking was probably on target. I believe the separation individuation theory. I think borderlines do need to grow up. Easy to say. Being a healthy parent over a prolonged period of time to an adult-sized, emotional 2-year-old can be quite a challenge. Although that's the challenge of doing work effectively with borderline. Another glimpse of the true nature of the borderline, a more clinical look, is provided by the MMPI. Here's a schizophrenic's MMPI up here. The paranoid scale is up and the schizophrenic scale is up. Now clearly schizophrenia is a more severe disorder than a borderline disorder, but it's a more contained disorder. The schizophrenic is way off in his own world, but he's likely not to be disrupting the world of the next guys. Here's the depressives MMPI. The depression scale up, the rumination scale is up. Here's a borderline's MMPI. Everything is up. A borderline is calling out for help. They're reporting experiencing all possible symptoms. The borderline disorder is an expansive disorder. The borderline reports experiencing somatic symptoms, depressive, hysteric, antisocial, paranoid, obsessive-compulsive, schiz, manic symptoms, and they may report experiencing any of them or display all of them. Now, other psychological tests that are used include the TAT, the thematic apperception test. Here, I'll pass this around. The TAT shows the patient kind of an ambiguous picture, and the patient has to make up a story about it. Borderline's TATs frequently have themes of hurt and anger, separation, loneliness. Borderline's Rorschachs have signs of impulsivity, aggression, depression. But none of these psychological tests quite captures, in such stark terms, the essence of the borderline as I believe the MMPI does, and differentiates it from other disorders. Now, in dealing with borderline pathology, we have what we refer to as borderline tendencies. The DSM-3 kind of zeroes in on those borderline tendencies quite nicely with those 8 features. Then again, we have what we might refer to as the world-class borderline. And I think we're all familiar with it. They cycle back into the hospital after pretty regular periods of time. And one common observation made of such patients is that they display symptoms that will vary in intensity from mild to severe to mild in a rapid period of time, or symptoms that will appear and then disappear, then appear, making it difficult to just narrow down a few symptoms that are most characteristically borderline. What I'd like to do at this point is to break down the borderline personality into just a few core features, either styles or themes, that hopefully might characterize a borderline. The first core feature is a style that borderlines display, and it's a disturbance in their cognitive style. Borderlines often have difficulty focusing attention, and they lose relevant detail. Borderlines might not be able to tell you or relate to you the events leading up to hospitalization. They may distort the significance of events, either exaggerating them or minimizing them. Borderlines will display cognitive styles typically associated with hysterical reactions, dissociation, memory difficulties, amnesia. The reason for this is that many borderlines, and some would say all borderlines, have experienced traumatic events in their life, traumatic physical abuse, traumatic sexual abuse. And these kinds of traumatic events are what form the basis for a person learning to block out painful experiences by such dramatic ways as dissociation. Or in an extreme way, multiple personalities. Borderlines easily embrace the notion of multiple personalities. It allows them to block out painful areas of their consciousness or experience and leave them alone. Something which is very characteristic of borderlines to do. However, I wouldn't consider such patients true multiple personalities. The other side of this tendency to block out thoughts is borderlines, their morbid introspection. Borderlines can seem totally preoccupied with their thoughts and their thought processes. And their thoughts may appear to be focusing only on a few themes. Borderlines' thinking appears repetitive and almost flooded with negative images and memories. The images, the memories usually focus on violent, destructive themes. The borderlines typically thinking about hurting themselves or hurting someone else, and they may appear consumed by such thoughts. The development of the diagnosis post-traumatic stress syndrome is pertinent here. The key symptom of this post-traumatic stress disorder is the recurring and intrusive recollection of a traumatic event or a traumatic memory. And this diagnosis has a tremendous overlap with borderline disorder. And the reason is that many borderlines have, as I said, experienced these traumatic events in their lives. And some people might consider a borderline disorder a kind of a post-traumatic disorder. And so I wouldn't waste too much time trying to differentiate whether or not there's a post-traumatic stress disorder involved or a borderline disorder. It can be an impossible determination at times. Do borderlines get psychotic? This is a difficult issue. I used to think that borderlines did not get psychotic without substance abuse being involved. And I still do think that the leading cause of psychotic deterioration with borderlines is substance abuse. In fact, I'd go so far to say is, when you see a drug-induced psychosis, if you can rule out a mental illness, there's probably borderline pathology involved there. After all, a lot of people abuse stimulants without getting psychotic. And something must differentiate why certain people get psychotic and why others do not. And I think borderline pathology is probably the explanatory variable there, or what explains that. But aside from this issue of substance abuse, borderlines rarely get delusional or hallucinate. But this doesn't mean that they don't get psychotic. Borderlines' thinking at times can be so confused, so disorganized, that they appear to be in a trance-like state. They appear disoriented. Invariably, if you try to tune into their thoughts while they're in that state, again, you'll find out they're into some repetitive negative image or hostile image, hurting themselves or hurting someone. In fact, the borderline appears out of touch with reality at such times, and they're invariably self-destructive at such times too. this raises a difficult issue with borderlines, and that is, are they out of control when they're self-destructive? When we observe a borderline acting out, there seems to be such an obvious attention-seeking component to their behavior that it seems like, how can you consider that psychotic? Further confusing the picture is the observation made that borderlines can purposely place themselves in a trance-like state in order to be self-destructive. However, if you just consider and look at the quality of the cognitive state the borderline is in at such times, it does, by golly, look to be out of touch with reality, and therefore, by definition, psychotic. The psychotic episodes in this instance are usually very brief, and oftentimes may not require medication. And they'll usually occur, aside from the drug abuse issue, they'll usually occur in situations that are very emotionally charged for the borderline, which for the borderline is when they're feeling too close to someone or they're feeling like they're being abandoned by someone. Perhaps the most evident disturbance in cognitive style seen with borderlines is their tendency to short-circuit their thought with action. Now this may sound like a highfalutin way of saying they act out impulsively, but with a borderline, their acting out seems so clearly an extension of their thinking, and yet a blocking off of it. Borderlines will abruptly leave groups. They'll throw things. They'll make a provocative suicide gesture right in front of you while they're talking about something very hurtful, or while they're thinking about something very hurtful. This is why having a borderline verbalize, and then verbalize some more, is probably the most reliable and strongest intervention you have with them. It interrupts this pattern of acting out. A second core feature or characteristic style of borderlines involves disturbances in emotional intensity or emotional lability. First of all, with the emotional lability, borderlines have mood swings all the time. They fly into a rage. They have emotional over-responsiveness. But the disturbance in emotional intensity is probably the most disturbing, the most troublesome, the most outstanding component of borderlines affect. Borderlines report feeling things intensely, and they often report feeling overwhelmed by the intensity of their feelings. Feelings they have are anger, depression, emptiness, neediness. But borderlines also report feeling emotions such as love intensely. Now, how we respond to a borderline's feelings is very important. The tendency is because borderlines' feelings shift so much and vary so much, their feelings must somehow be superficial or shallow. Moreover, the shift from affection to anger towards the same person in a rapid period of time, or from intensely loving one person to intensely loving another person, again in a brief period of time, does create the impression that their feelings are fickle. But the important thing to remember is these are our impressions. It's further important to remember that from the borderline's perspective, their feelings are intense, and in fact overwhelmingly so. While working with borderlines, their feelings oftentimes seem dramatically expressed, provocatively expressed. And again, it gives you the feeling that there's something something ungenuine about their feelings, or even manipulative. But we need to see that the maladaptive behavior patterns borderlines get into, their self-destructive stuff, their desperate attempts to avoid being alone, their provocative behavior, oftentimes stems from their inability to handle the intensity of their feelings. It doesn't help for a therapist to tell a borderline that they're exaggerating the intensity of their feelings. While borderlines are obviously troubled by the intensity of their feelings, they don't seem able to maintain their feelings at a more calm, neutral level. Instead, they drive each relationship towards greater and greater heights of intensity and involvement as if nothing else mattered. Or they may turn around and abandon a relationship with great emotional despair. Of course, the borderline will claim that they were the ones who've been abandoned. What can be most troublesome with borderlines is how they evoke strong responses in us. This is particularly difficult as mental health professionals. Borderlines have an uncanny knack for triggering intense emotional responses in us, which could make it easy for us to lose a professional perspective. And what happens is we wind up playing out the dominant themes in the borderline's life, the dominant pathological